हो जाएगा। सुशील ऑन है?
Yes, sir.
ऑन है रिकॉर्डिंग?
Yes, sir.
Okay. Good morning, friends. I'm Dr. Pankaj Garg, President-elect IAP Delhi, and I welcome you on behalf of Delhi IAP on another session of eNeo course on neonatology, which we are doing for office-based pediatricians. As you know, it's a series of 15 sessions, and today we are in the 12th session. Up till now, we have a very excellent response, and we have around 700 registrations and a lot of questions asked in this platform. Before I open today's session, just one thing I want to mention. Today is also IAP CPR or BLS Day, which is celebrated by Indian Academy of Pediatrics in memory of Dr. Anand. So today we also have arranged a training program of BLS at nearby park. So I'm just coming out from there. So I request all that whosoever is in whatever capacity possible, try to train people in BLS, because this is something which is our combined responsibility. So now coming back to today's session is going to be moderated by Dr. Ranjan Pezawar. Dr. Ranjan Pezawar is a great neonatologist. He is FRCP and FRCP-CH. He is FIAP and FNNF. He is Professor of Neonatology and Chief Neonatologist at People Tree / Meenakshi Hospitals, Bangalore, India. He has been President of NNF 2021, past President of FIOPS, Federation of Asia Oceania Parental Society. He is currently Advisor of FIOPS. He's also been past President of Neonatology Chapter of IAP. He has been Convener of IAP International Liaison Committee and is Editor-in-Chief of Index Journals, Parentology and Nursing Digest. So more than that, he's such a lively person. Whenever you talk to him, you get always positive energy. And I always feel very privileged to invite him to this session. So I invite Dr. Alok has also joined. So before I hand over to Dr. Ranjan, I request Dr. Alok Bhandari, who is IAP Delhi President, to say a few words. And then I will hand over. Dr. Alok, sir.
Good morning, friends. Welcome, Dr. Ranjan, sir, to IAP Delhi platform. We've been together at NNF platforms for more than 3 decades now, but it's a pleasant sight to have you with us on IAP Delhi. Currently, I'm holding additional charge of President of IAP Delhi also. So in that capacity, whenever we started this neonatology course, so Dr. Ranjan was always the name in front of us as a first frontline neonatologist who is dedicated as almost, I can say, a good portion of his life to the cause of neonates, improving the neonatal health. And he had introduced very unique features as president of NNF, which are really memorable. But if we can go on and on about Dr. Ranjan also, but then timing is a constraint. We always try to be very punctual in starting our Sunday morning session with our guest and host speaker as Dr. KUMAR, ANKUR, a very talented neonatologist from Delhi, a Max region. But I'll request Dr. Ranjan to take over the proceedings, please.
So over to Dr. Ranjan, sir.
Good morning, Dr. Garg. Thank you for your generous introduction. It is nice to see all my friends, you, Dr. Bhandari, and the speaker himself, Dr. KUMAR, ANKUR. I really commend you people and also your, the coordinating team for putting out such an innovative and very useful program, eNeo course online. And I looked at the list of the 15 lectures. They are very, very nice. And many of them are topics like today, which are seldom discussed in routine conferences and in textbooks. So that is one thing I liked. Like today's neonatal pharmacology is very important because as a practicing pediatrician, as an office pediatrician, we should realize that the neonatal pharmacology is quite different from the grown-up children or the older children. The newborns' metabolism is different, pharmacokinetics is different, and the dosages are different. And a little bit of mistake in prescription, selection of drug, or administration of drug can lead to catastrophes. So I do not want to stand between the, I'm sure, a very comprehensive lecture which Dr. Kumar Ankur is going to deliver. But I would just say that once again, kudos to the IAP Delhi team and the team which is running this course, especially Dr. Alok Bhandari, Pankaj Garg, Mukesh Dhankar, and all of you who are involved in this particular program. So I think I'll hand over the mic to Dr. Kumar Ankur. Please go ahead, sir.
Let me just introduce Dr. Kumar Ankur for the benefit of the audience. Dr. Kumar Ankur has been alumni of Sir Gangaram Hospital. He's did his DNB neonatology from our center. And right now he has a very peak position. He's the chief neonatologist at Max Super Specialty Hospital, Dwarka, as well as chief neonatologist at BL Kapoor Max Hospital. He also has been a very active member of NNF Central, and as well as he has held many important positions in NNF Delhi, the secretary of NNF Delhi, and the many it is been a key role in reviving the NNF Delhi, which was dormant for some period of time. So I'm sure he is going to do a lot of justice to this topic. As Dr. Ranjan said, it's a very seldomly discussed topic. So I'm sure Dr. Ankur will do justice to this. And for all the delegates, whatever questions come to your mind, please post them in Q&A session. I know you know this, but at the end of session, we promise that we take care of all the questions which are posted in Q&A session. If you have something to speak, you can also raise your hand, then I will upgrade you into the panelist channel, and then you can ask question directly also. With these words, over to Dr. Ankur.
Thank you, Pankaj sir. So am I audible, sir?
Yes, sir, you are audible. Please share your PPT also.
Yes, you are.
Yeah. Is it visible, sir?
It is visible and very well audible. You can go ahead.
Good morning, all of you. First of all, I would like to thank the IAP Delhi team, the President Alok Bhandari sir, the President-elect Pankaj Garg sir, and our teacher Dr. Ranjan Pijawar sir. Thank you for the kind introduction. So welcome all to this eNeo neonatology course, and today we are discussing about the neonatal pharmacology. So what Dr. Ranjan has told that it's not been taught and it has not been there in anywhere. So Dr. Pankaj has requested that I should talk about that part of neonatal pharmacology which is being used in OPD or day-to-day practices that could be useful for the office-based practitioners. So I have not used anything which is being used in the NUCNIC area. So I have nothing to declare. There is no conflict of interest. So even though I use some medication, some pharmacological name, some company name, so please pardon me, there is no conflict of interest. So I have used in entire presentations, infant, those who are more than 1.5 kg, because most of the infants, those who are born below 1.5 kg, they would require some durations of NICU stay. So I avoided using infant, whatever the medications being used, in less than 1500 grams. So I started with at the time of birth. So I'm not going to discuss many things about the resuscitation. So at time of birth, we use only two medications, adrenaline and normal saline. Apart from that, there is no other medications being used in the neonatal resuscitation area. And after birth, we use vitamin K, immunization, and that's all. After routine care, you use vitamin K to all infants and immunizations like BCG, OPV, and hepatitis B. First of all, something about vitamin K1. So there are two vitamin Ks available in the market. So vitamin K, the drug of choice is the natural one, known as a phytomenadione. The other choice is synthetic one, that is Menadion. However, the natural one is the drug of choice. But studies have shown that both natural and synthetic can be used. In absence of, if you are not getting the natural one, you can give Menadion. The only concern with the Menadion is that sometimes it can cause hemolysis. Because most of the studies have included infant on the day one, they give vitamin K immediately after birth. So in many of the time, you don't know the G6PD deficiency. So the studies have shown there is no increase in hemolysis even if you use the synthetic Menadion one. Dose is very clear. For infant, more than 1 kg, 1 milligram is the drug of choice, and it should be given intramuscular. There is some controversy about infant, those who are less than 1500 grams or less than 1,000 grams. If you look at the efficacy of vitamin K1, we look for protein-induced vitamin K absence as a marker for vitamin K deficiency. And for overload, you look for vitamin K epoxide. Studies have shown that if you give 0.5 to 1 milligram for the preterm infant, the level of the vitamin K epoxide will be very high. That is 5 times higher than the fasting adult level on day 10 of life. That is why infants who are less than 1500 grammar, we should not use vitamin K more than 0.5 milligram. In fact, most of the studies have found that if you give 0.3 milligram per kg for the preterm infant, that would suffice for any infant, those who are less than 1500 grams. Immediately after birth, we all give BCG, hepatitis B, and neonates. There is no confusion if your baby is more than 2 kg. But what happened to infants, those who are 1.5 to 2 kg, because many of them, they would require an ICU hospitalization. There are always a concern that these are premature. Their immune systems are very mature. So that's why they are more prone to getting infections. Not only that, the concern of pediatrician is that if we give vaccine, whether it's going to be effective or not. That is a major concern. So 2 or 3 meta-analyses have found that infants between 0.69 kg, that is 690 grams, up to 2.5 kg, they have included many studies from 27 to 37 weeks of gestation age. They found that even if you give BCG vaccine on day 1 of these infants, there was no increase in adverse reactions. There was no increase in mortality. In fact, there was a similar rate of BCG scar and tuberculin skin test conversion rates were same. So that is why healthy neonates, those who are stable more than 30 weeks or 1.5 kg or more, we should offer vaccines on the day 1 or at the time of discharge BCG. So the current recommendation is that BCG, birth dose of OPV, can be safely and effectively given to low birth weight preterm infants after stabilization and preferably at the time of discharge. Something about hepatitis B, specifically infants those between 1.5 to 2 kg. What WHO recommends? WHO recommends that a birth dose of hepatitis B vaccines can be given to even low birth weight and premature infants. There are certain concerns about immunogenicity of birth dose of hepatitis B vaccines because few studies have shown that suboptimal response. However, what the WHO, AAP, IAP recommend that we should consider birth dose followed by 3 doses of standard primary series that would take care of hepatitis B status of all premature and very low birth weight infants considering between 1.5 to 2 kg. What about well baby when you are going to be discharged? We know that mother milk is insufficient in vitamin K. So that's why you give vitamin K immediately after birth to prevent the hemolytic disease of the newborn. And the other thing absent in the mother milk is vitamin D. Those infants who are exclusively breastfed, vitamin D3 dose should be offered up to 1 year of age. That is in a dose of 400 units per day. There is some confusion whether the baby is breastfed, partially breastfed, on exclusively formula feed. What Global Consensus Recommendations on Prevention and Management of Nutritional Rickets 2021 recommends that irrespective of breastfeed or formula feed or partial breast or partial formula feed, we should give vitamin D3 in a dose of 400 units per day to prevent rickets. They found that if you use in this dose, you can prevent rickets, that is a radiographic sign of nutritional rickets, till 1 year of age. One of the studies has found that infant, if you're getting a 1 liter formula feed, that comes around 6 kg of weight, they would require no extra vitamin D. But we should not go into that confusion. So we should follow one guideline that during the first year of life, irrespective of the type of feed, whether breast or formula, we should offer 400 units of vitamin D per day. Do we really need calcium supplementations in the well baby? No, because mother milk is sufficient to provide calcium for all the infants, those who are more than 1.8 kg. So there is no need to supplement calcium apart from vitamin D. If baby is getting enough breast milk, the dietary intake of calcium to prevent rickets, they must be getting around 200 milligrams per day. That is what global consensus recommendation is given, that we should not supplement calcium to all well baby at the time of discharge. In the initial slide, I told that we are going to discuss something about infant between 1.5 to 1.8 kg and 1.8 to 2.5 kg. So we have divided these two groups, these 1.5 to 2.5 into these two groups. The concern is that whether they need vitamin D3, whether they need calcium, phosphorus, multivitamins, and iron. So we'll discuss each topic one by one. So infants who are born less than 1.8 kg, we generally follow the SPACAN guideline, which was published in year 2022. What they recommend about vitamin A dose in an international unit per kg per day, they recommended that we need around 1333 to 3300 international unit per kg per day of vitamin A per day for infant less than 1.8 kg. As far as vitamin D is concerned, it should be given 400 to 700 international units per kg per day, and we should not go beyond 1000 units because there is no advantage giving high vitamin D. And the vitamin C in a dose of 17 to 43 milligrams. The all multivitamin is already given, that in a dose of B1 140 to 300 microgram, riboflavin B2 200 to 400, pyridoxine 45 to 300 micrograms, tocopherol vitamin E 2.2 to 11 milligram, and zinc in a dose of 2.3 milligram. In the market, there are various multivitamins are available. What I found that this group of vitamin, if we use in a dose of 1 ml, you can provide all the recommended dose of as advised by SPACAN. That would include vitamin A, even the vitamin D in a slightly lower dose, because we are going to add extra vitamin D in separate drops. What they have recommended that we want a vitamin D status in a sufficient status is defined as vitamin D level in a level of more than 50 nanomole per liter, and severe deficiency is defined as less than 25 nanomole per liter. We should avoid any level more than 122 nanomole per liter during the first few weeks of the life. So it is very clear. If you use this, if you use this, just a second. If you use this multivitamin, you can cover all the recommended dose. What about the calcium in infant 1.5 to 1.8 kg? The calcium is recommended in a dose of 3.5 per kg per day. That comes around 120 to 200 milligram per kg day, and the phosphorus just half of the calcium. So in the market, the calcium phosphorus combinations are available. So whenever you are prescribing the infant, those who are less than 1.8 kg, so you should look for that suspension should have a calcium phosphorus ratio in a dose of 2:1, because many of the calcium phosphorus calcium carbonate are available in the market. They are being used. They are not being recommended for infants who are less than 1.8 kg. Next comes iron supplementation in the well baby. Those infants who are term breastfeeding or partial breastfeeding, we should start iron not more than 1 milligram per kg per day at 4 months of life. So before 4 months, there is no need to add iron. However, if the infants are low birth weight, we should start iron at the age of 2 to 6 weeks of life in a dose of 1 to 2 milligram per kg per day. The question comes as which iron is the best iron? Almost all body have recommended that the ferrous sulfate continues to be the gold standard and the preparation of choice. But the concern with the ferrous sulfate is that they are not easily available. The shelf life is very less. They have bad GI effect. They can cause gastric irritation, sometimes vomiting, sometimes constipation. So these ferrous sulfates are not commonly being used. The acceptable alternatives include ferrous fumarate, gluconate, ascorbate, and the colloidal iron. These 4 irons are easily available and they can be used, and they are being used for many, many years. We should avoid the newer one, the ferric diphosphate, because no studies have ever shown any benefit in an infant less than 6 months. And so beyond 6 months, there are studies and mainly coming from the adult side. So we should avoid iron which contains ferric diphosphate, and we should, continue only ferrous fumarate, ascorbate, and colloidal iron. If you look at the guideline for infants less than 1.8 kg, the iron dose is recommended in a dose of 2 to 3 milligram per kg per day. Initially, the recommendation was slightly higher. So now they have stick that we should not give iron more than 3 milligram per kg per day unless until the conditions where the ferritin is less than 35 to 75 microgram per liter. And if you want to use more than 3 milligram per kg per day, you should not use for a longer period, and you should switch to again 2 to 3 milligram per kg per day. Folic acid recommendation is in a dose of 23 to 100 microgram per kg per day, and vitamin B12 in a dose of 0.1 to 0.6 microgram per kg per day. So again, in the market, there are many iron preparations are available. These two combinations, these two are being very commonly being used. And if you look at this combination, if you use 2 drops per kg, that would provide enough iron, that in dose of 2 to 3 milligram per kg per day, that also provide enough folic acid and enough vitamin B12. And most of the other preparation, either they contain less folic acid, they have either no vitamin B12. So infant, those who are very small, 1.5 and below, and between 1.5 to 1.8, while prescribing this medication, you should look for that. So just to remember, if you're using these preparations, 2 drops per kg would be enough. What Sagan has already commented that we should not use vitamin B12 in a dose more than 0.6 microgram per kg per day, because if you're using a preparation that contains high vitamin B12, they can lead to very high blood level of vitamin B12. Now, the other group, that is infants, those who are between 1.8 to 0.5 kg. We should not use multivitamins in that group of infant because it is not required. They don't need calcium supplementation because the breast milk or alternative milk would be enough to provide enough calcium. We need vitamin D3, that is for 400 units per day, and it should be continued till 2 years of age. And iron, not more than 2 milligram per kg per day, and maximum dose is recommended 15 milligram, and we should continue till 2 years of age. So any infant beyond 1.8 kg, you need only vitamin D and iron, and it should be continued till 2 years of the age. There are certain tips of giving this liquid medication to babies, infants who are less than 1 year. Preferably use syringe or very small spoon. Keep the baby upright, slightly head up. Try to put the syringe inside the cheek. First, allow the baby to suck. So that is why in between feeding, when the patient and when the baby is ready for the feeding, should be the right time, because they would swallow very easily and they won't choke. Try not to mix any medications with the breast milk, because if you put or add any medication with the breast milk, they would alter the taste of breast milk and there would be very oral aversions. They are not uncommon in small babies. There is always a concern when to replace the bottles once you open the bottle. So I've tried to gather the information, more evidence, but I could not get. So first, what most of the studies have recommended, that you should follow the product insert guideline, because most of the drugs are stable even after opening the bottle. They are effective until the expiration date is not come, provided they have stored correctly. And if you use the syringes, clean the syringes with the sterile water and keep it there, and don't put again into the bottle, because it can lead to so much of the, if you put the syringe in the mouth, they can get some bacteria and they can contaminate the bottle. So you can use bottle separately and the syringe separately to avoid any contamination. Few of the infants between 1.5 5 to 2 kg. They come, they're not in your OPD, they don't gain weight. So many of us do provide that they advise that can we add human milk fortifier? So what the recommendation is that the recommendation is that if the infant is more than 32 kg weaker, more than 1.5 kg, try to avoid any human milk fortifier. Take the history, look for weight monitoring, check whether is baby getting adequate feed. If not getting adequate feed, ensure feeds. Look for the breast milk amount. Try to express the breast milk. Look at the amount of the breast milk. If it is not available, first consider alternative feed and try to ensure adequate amount of the feed. Call the patient on alternate day or maybe on every weekly to check for weight gain. Try not to jump on adding human milk fortifier. They are just fortifier. They are not going to increase the calorie. So it is not recommended. Don't because if you are allowing the mother to mix breast milk with the fortifier at home, there is always chance of infection. It's like a bottle feeding, always the risk of contamination. There would be always the risk of wastage of breast milk. If the baby left that milk, you can't store the mixed human milk fortifier milk anywhere because there are chances of infection. There are certain studies have found that one of these particular human milk fortifier can lead to hypercalcemia or sometimes very high doses of vitamin, as I already told. So try not to add any fortifier for infant who are 1.5 to 2 kg. Now cord care. So even NNF CPG guideline have recommended that the best cord care would be keep it clean, keep it dry, try to put the diaper below the cord. Only conditional recommendation is that where chlorhexidine is being used to apply it over the umbilical cord in term or late preterm infants, in the settings where the neonatal mortality rate is very high, that is in the range of more than 30 per 1,000 live births, or high incidence of omphalitis, they have found that if you use chlorhexidine, they can lead to 40% reduction. But again, the quality of study was not that poor. So the WHO, the NNF and IAP, what recommends that cord should be kept dry. Don't put anything, because I have found that many of them are still using gentian violet, many of them are still using one of the neosporin powder. So if you're putting all these, I mean, gentian violet is okay. If you're putting some powder, they would delay in cord dehiscence and the cord won't dry. So keep the cord clean and dry. That is the only recommendation. Once the cord gets fall, the umbilical granuloma is not uncommon. So in your practice, you must be getting umbilical granuloma. So if you look at the data, 1 out of 500 births, these are commonly appears after the cord falls off and with swelling and discharge from the granuloma. While clinically examining the umbilical granuloma, just rule out the signs of infection. That is, look for redness, tenderness, induration. If these all things are there, try not to treat locally. Just first rule out whether it's omphalitis or not. Traditionally, for many years, we were using silver nitrate. However, these silver nitrate sticks are not easily available. They are available online in the Amazon, but they are very costly. The cost would be around 250 rupees per stick. They cause a lot of spillage. They can lead to change in the color, burn. It's very difficult to apply by the parent, and you need multiple applications. Nowadays, there is no great data. When there are many small studies are available, they found that common salts are very much effective. How to use this common salt? Put a pinch of salt with you after you're washing your hand. Spread over the granuloma. Put a sterile gauze and left it for 10 to 30 minutes. If you apply twice daily, there are chances 50 to 100% they would, completely recover within a day. If you are not using this method because it is very difficult to apply sterile gauze, putting for 10 to 30 minutes because of so many patients in the OPD, you can't wait. You can, demonstrate to the patient they are equally effective. There are one or few studies they found that putting common salt in a sterile water and using your earbud and apply around this 2 to 3 times a day, they would also lead to complete clearance in nearly 50 to 100% of the cases by 1 week of life after applying this common salt. So After a few days of life, once your patient is going home, if they are not on breastfeeding, if the care is not proper, they can get this oral thrush or oral candidiasis. Sometimes you can also see these type of coated tongue and these thrush. How to differentiate between thrush and this coated tongue? So thrush is a condition in which the white curd-like lesions are present, not only the buccal mucosa, cheek, tongue, palate, and infant because if to use to try to lesion, they because they're very intimate. Whereas it for because tongue is clear, the movement open the palate, movement during movement. If the tongue is adequate, like in a country or ankyloplasia, the way we use for, you can get these type of coated tongue. Don't trust the
Ankur, the voice is cracking little bit. Maybe maybe little closer to the mic. It is fine. Voice is cracking. Maybe little closer to the mic.
So the ear.
You can go ahead.
Minute, one.
Sir, am I audible now?
Yes, yes.
Clear? Is it clear, sir?
Yes, yes, it is audible now.
Okay. So, the drug of choice for this oral thrush, oral candidiasis is the oral nystatin. Oral nystatin suspensions is available in the market. The dose is 1 ml. 1 ml contains 1 lakh units. The dose is around 2 lakh units QID. The success rate is 53% by 1 week. So most of us, what we do, we tell the parents, they do apply for a few days and they stop. That's why the recurrence would be more common, and you label it that this is not improving. Whereas you should ensure that parents should apply this oral nystatin at least for 10 to 15 days to get a 80% corrections. They are very well tolerated. The only issue is that they have very high osmolality in the range of 2,800 milliosmol per liter. So there are chances that if you apply this in a preterm infant, they can cause feed intolerance and sometimes necrotizing enterocolitis. So ensure that you should avoid in a preterm infant. The alternative treatment is clotrimazole oral paints. They are easily available. I think they are more commonly used as compared to oral nystatin because of the availability. But the evidence is more in favor of oral nystatin because they are being commonly used. The only problem is the clotrimazole is that they cause lot of burn, pain sensations. That's why we don't, enjoy using clotrimazole whether you apply orally or perianally. So it is your choice on the availability. Both are nearly equally effective, but the drug of choice is oral nystatin. Oral thrush, if they don't respond to topical, antifungal, if you have given a fair trial of at least 10 to 14 days and still baby is having recurrent oral thrush, you have to rule out the immunodeficiency state. But many of time they do respond. Even after applying oral antifungal, you should add oral fluconazole in a dose of 3 milligram per kg per day for 7 days. The dose of fluconazole for other systemic invasive fungal infections are different. They are not meant for this topical applications. For oral candidiasis, the dose is different.
अंकुर, अब आवाज फिर से चली गई आवाज.
Okay.
बीच में बहुत अच्छी आ रही थी और फिर से कम हो गई.
I think so. Shall I try other one, sir?
हाँ नहीं, अब तुम पास आते हो तो अच्छी आ जाती है. थोड़ा पास आ जाओ इसके.
हाँ नहीं, मैं पूरा पास ही हूँ. I think.
अच्छा अच्छा,
पूरा पास.
मुझे लगा ईयरफोन्स.
Earphone हटाए. Just give me 1 minute, sir. I'm trying with this.
हाँ sure. हाँ.
Sir, please let me know. Am I audible? Sir, am I audible?
Now very clear. Now you can speak.
Clear, sir?
बिल्कुल clear है. बोलिए.
Okay. Thank you, sir. Sorry for the interruptions. So even though I applied, the direct Ethernet, but some network issues there. So something about the Candida diaper dermatitis. So topical versus oral plus topical. What the studies have found that the relapse rate was decreased by 50% when you apply both oral and topical nystatin, 33% versus 16%. So most of the time, the Candida diaper dermatitis, in the case you generally apply again clotrimazole. The only issue with the clotrimazole is that it causes a lot of burn. So preferably, if you have nystatin, you can use both oral nystatin and local nystatin also. Otherwise, if you are not getting nystatin, even for the Candida diaper dermatitis, you can apply the clotrimazole. So after first week, generally after 10 days of the life, the so-called colic is not uncommon. They generally start during the second week of life, and they can last up to 4 months of life. The theory is that because the gut size is very small, the milk contain a lot of lactose, they can cause a lot of gases. But the definition of colic is that if the pain is lasted for more than or equal to 3 hours per day and occurs on more than 3 days per week in otherwise healthy infant for a less than 3 months of life, then that baby qualify for colic. I think almost all baby get some or other medications in OPD. So the most of the time they either get simethicone related preparations or dicyclomine preparations or some probiotics, that is lactobacillus reuteri. If you look at the evidence, what is said, if you're using simethicone, they decrease intraluminal gas. There is no difference in the outcome. The best part is that there is no adverse effect found in any studies. However, a few of us use dicyclomine. The concern with the dicyclomine is that they affect cholinergic system and sometimes affect the neural cholinergic system also. The anecdotal studies have found that they can lead to respiratory distress and seizure. So that is why it is absolutely not safe to give dicyclomine in less than 6 months of age. Try to avoid or don't give dicyclomine related to any preparations. The third and nowadays very commonly used is the probiotics lactobacillus reuteri. The meta-analysis has found that if you use lactobacillus reuteri for more than 7 days, they can decrease to less crying, fussy time. Again, is a subjective assessment. But one thing all studies have found that this probiotic is helpful only when if your patient is on exclusively breastfeeding. If the patient is on formula feeding and if you are giving this probiotics, they are not giving any relief to the patients. One point is very important for colic to remember that it is a painful condition but harmless condition. So you have to counsel the parents that they can cause pain but they are harmful, and some of us do use maybe paracetamol in case of extreme pain because they can relieve the pain also, though it is not recommended. In cases of colic and severe GER, what Nespegan and Nespegan 2018 have defined GERD in refractory GER is that GER is the passage of gastric content into the esophagus with or without regurgitations and vomiting. GERD is when GER leads to troublesome symptoms and complications. Refractory GERD is not responding to optimal treatment even after 8 weeks. We generally follow this flow chart. This is very important to understand that even in an infant where you suspect a GERD, take complete history, do proper physical examination, look for the weight gain. What is the weight gain? The baby has gained adequate weight gain. What are the clinical signs? Any red flag signs are there not? If these red flag signs are not there, then look for whether the baby is overfeeding with the bottle. If the baby is not overfeeding on exclusive breastfeeding, they have recommended NASPAG and recommended that we can thicken the feed with the cereals, but that cereals are not easily available in India. Try to ensure continue breastfeeding. If they get improved, then continue management. If they don't improve, even after avoiding overfeeding, maybe adding some feed thickener, consider 2 to 4 weeks of protein hydrolyzer or amino acid formula, which is not possible specifically if your baby is breastfeed. For us, what we can do, we can offer a cow milk free diet to the mother. So mother should not take any cow milk source and give a fair trial of 2 to 4 weeks. If the baby get improved, then it's very good. Otherwise, you can give a trial of hydrolyzed formula. So it is not possible in that case. So you should refer the patients to the pediatric gastroenterologist. What I am trying to emphasize here is that you should add proton pump inhibitor only after the alteration in the feed, avoiding maternal diet from the cow milk. Then and then you can add proton pump inhibitor. Before that, you should not add proton pump inhibitor. The newer guidelines have strongly recommended there is no role of positional therapy, massage therapy, prebiotics, probiotics, herbal medications, domperidone, or metoclopramide. So no domperidone at all for suspected GERD, whether it's a mild, moderate, or severe. In cases of not responding to the feeding trial, change in the type of formula, then you can consider for a long-term durations of proton pump inhibitor or never H2 blocker. For more than 1 month, you can use esomeprazole in a dose of, if the infant is less than 5 kg, use a dose of 2.5 milligram per day. For infant more than 5 kg, use a dose of 5 milligram. In the market of one sachet is available, one sachet contain 10 milligram. So if the patient responds to your, modifications of feed, it's better to get an opinion from pediatric gastroenterologist. If the facility for pediatric gastroenterologist is not available, then you can give a fair trial of proton pump inhibitor and send them early to pediatric gastroenterologist. Something about the skin infections. So these two infections are very common, the bullous impetigo and the omphalitis. So bullous impetigo, you can, in your OPD, if your patient is hemodynamically stable, growing well, taking feed well, then you can deroof all the lesion in your OPD after washing your hand or using your sterile gloves. You can offer oral moxicillin, cloxacillin for 5 days. You can apply fusidic acid or mupirocin. But in the last 2-3 years, what I found that whenever I do swab, I found in most of the cases it is not MSSA, rather MRSA are very common in last 3 years. I have did one of the study at our places. But if the lesions are less in number, they do respond to oral treatment. Something about the omphalitis, even though the studies have found that cephalexin, one of the large study from Pakistan, they are very effective in more than 90% of the cases. So in our hospital, all the omphalitis cases, all nearly 100% were MRSA positive. None of them were MSSA, and they don't respond. So most of the studies have tell that if the omphalitis is moderate or severe, try to admit the patients, give IV injections, and do all the workup. So most of the time, the sepsis workup is negative. Only the local swab would be done, which can either get MRSA or MSSA. So my advice is that even if you are treating a patient on OPD basis, a case of omphalitis, try to send at least a swab culture so that you will get the culture report, and then you can change the antibiotic according to that, whether it's a MRSA or MSSA. Something about the infantile hemangioma. So I'm not going to the detail of when to treat hemangioma. There is American Academy of Pediatrics guidelines are available. In fact, if the lesions are large enough, they cause disfigurement, they are affecting the eye, if there are chances of getting ulcers. So these type of hemangioma, they do qualify for treatment. And the drug of choice is propranolol. It is a non-selective antagonist that act on both beta 1 and beta 2 adrenergic receptors. They found that if you use for adequate durations, they can clear 95% times. The mechanism of action is not very clear. They can cause vasoconstriction, they decrease the angiogenesis, they can cause apoptosis. That's how which can be managed easily on OPD basis. However, the recommendation is that don't treat infant on OPD basis if they are less than 8 weeks. They would need a hospitalizations because the cardiovascular and respiratory issues. Infant, those who are more than 5 weeks or maybe 6 weeks, you can offer OPD treatment. The duration is at least for 6 months. Dose is 2 to 3 milligram per kg. That is a target dose. Start with a dose of 1 milligram per kg and gradually increase to 2 to 3 milligram per kg. The only issue is that the propranolol can cause hypoglycemia. So always offer only after feed. That you have to ensure, because this is one of the agent which can lead to hypoglycemia. The timolol is also being used, but the timolol is inferior. The correction rate is just 62%. They can vary between 40 to 83%. Only for a small infantile hemangioma, you can try. The Timolol 0.5% gels are available in the market. You can apply 1 to 2 drops twice daily for 6 to 9 months. The adverse events are not too much. They cause local irritations and sometimes bronchospasm. Something about the acute diarrhea. I think neonatal diarrhea is always serious, irrespective of, whether it's a mild dehydration or moderate. However, anything more than 5% dehydration, they should preferably be admitted, evaluated to look for bacterial infections or sepsis. Infant who are on breastfeeding, if the dehydration is less than 5%. So for every loose stools, you can add 10 ml per kg of ORS. That ORS 75 is safe for neonatal diarrhea. The studies have found, WHO has found that ORS 75 is safe. So you can use up to 2 months in a dose of 5 teaspoons per purge ORS 95. It has been recommended both by WHO, IAP and UNICEF, and try to continue breastfeeding. And there is no, don't change the type of formula. Please don't change, don't dilute or don't modify the formula. That would suffice for an infant with a mild dehydrations or no dehydrations. Whether we should use zinc in diarrhea in an infant less than 6 months? Yes, WHO recommends that. We can use zinc in less than 6 months of age. IAP recommends between 2 to 6 months of age in a dose of 10 milligram once daily for 10 to 14 days. What Cochrane review in 2016 found that the evidence does not support the use of zinc supplementation in children less than 6 months of age in well-nourished children in a settings where children are at low risk of zinc deficiency. However, in our setting, in a low middle income country, we should consider for giving zinc in a dose of 10 milligram per kg, 10 milligram once daily for 10 to 14 days of supply. Something about sucrose 24% gel, because it's nowadays available in the market. They can be used as a OPD analgesia. How they act? They cause activations of endogenous opioid system. The time of maximal effect is approximately 2 minutes and duration of effect lasts for 5 to 10 minutes. So preferably you can use this sucrose 24% gel while giving immunizations or vaccines, but they are slightly costly. So you have to consider that also. The only concern is that the osmolality is in the range of 1000 milliosmol per liter, but most of the studies have found that they are pretty safe, so we can use this. So the dose of this sucrose 24% gel in preterm infant is 0.5 to 1 ml of 12 to 24% sucrose solutions. In term infant, 2 ml of 12 to 24% sucrose solution is enough. It should be offered 2 minutes prior to immunizations or any painful procedures. Many of us do refer patients for the echo, MRI, CT scans, and frequently the chloral hydrate are being used, commonly used, but you should think about that before using chloral hydrate. The dose is very variable. They have used in a dose of 15 to 75 milligram per kg. In US, they have stopped using chloral hydrate. The reason of that, because they have very long half-life, unpredictable response, and they have found some death. So nowadays, chloral hydrate is a very poor choice as a sedating agent for procedures, because they can also be a carcinogens. They have found in mice studies. So specifically because most of the preterm would require MRI brain, so it is better to avoid in preterm neonates, because episodes of bradycardia are more frequent for up to 24 hours even after a single dose in a former premature infants. Gastric irritations, vomiting, paradoxical excitement can also occur. So this is not now FDA approved. So if you are using, try to avoid using in OPD settings. So something about the systemic symptoms. If the neonates come with some systemic symptoms, again, you have to examine. Thorough examination is the key. Look for signs of sickness. If the signs of sickness is there, admit the patients. If there is no signs of sickness, that means if the symptoms are proportionate for the age, symptoms means baby's activity, feeding pattern, heart rate, breathing, and urine output. If these all symptoms are proportionate to age, you can offer treatment on OPD basis. There are 3 groups of patients. 1, fever without focus. The second, respiratory, and the common, the ENT reasons, which can which can be encountered in day-to-day OPD basis. So let's discuss about fever without focus in more than 48 hours. So I think for pediatrician, we know what do you mean by the fever without focus. If the fever is persisting beyond 48 hours, if the symptoms are there like fever, vomiting, irritability, lethargy, poor feeding, failure to thrive, jaundice, hypothermia, hematuria, and the baby is coming from the community setting, they have never been admitted in the NICU, you should consider UTI as a first possibility. What should do? I think if the infants are less than 2 months, send all the sepsis workup. If feasible, if not feasible, at least do a urine dipstick test that should offer leukocyte esterase or nitrite. If you're sending your patients for urine test, make sure that that lab is doing leukocyte esterase or nitrite test and along with blood urine culture. Start empiric antibiotic. Wait for urine culture reports. If the baby is sick, septic, poor oral intake, try to admit the patients and start with IV treatment. The recent guideline published in the Pediatric Nephrology, they have suggested that the preference of oral over intravenous antibiotic therapy for treatment of all acute febrile UTI in all children except infants, those who are less than 2 months of age. So preferably, even with UTI with signs of sickness, you should admit the patients. The drug of choice is third generation cephalosporin or coamoxiclav as the initial empirical antibiotic therapy in children with suspected febrile UTI, and the duration is generally 7 to 10 days. Previously, it was 10 to 14 days. They have found that beyond 10 days, there is no advantage and the chances of drug resistance would be high. So try not to give, whether you are giving IV, IV plus oral or switch to oral therapy, not more than 10 days because this would lead to drug resistance. What and when to give prophylaxis? So again, the same guideline has suggested that there is no need to give any drug prophylaxis if the patient is diagnosed antenatally hydronephrosis till you get the final report, because adding prophylaxis in infant where the VUR is less than grade 3, there is no advantage. In fact, they would lead to increased drug resistance. So in fact, if you are getting an infant with antenatal hydronephrosis, 10 mm, 5 mm, 8 mm, try not to give any drug prophylaxis. So now it is not recommended. And if you have the report of high grade VUR that is more than 3, in that case only the prophylaxis is recommended. Which drug is recommended? We should not use cotrimoxazole and nitrofurantoin if the baby's age is less than 3 months, because in the case of G6PD deficiency it can cause problem, and there are many problems with the cotrimoxazole and nitrofurantoin. The drug of choice is cephalexin in a dose of 10 to 12.5 milligram per kg once daily dose. That would suffice. However, many of us do use amoxicillin. However, the recommendation is that amoxicillin should be used only if the organism resistance to all other agents recommended of prophylaxis. Then and then you should switch to amoxicillin. Otherwise, we should consider cephalexins in a dose of 10 to 12.5 milligram per kg. So once your patient is stable, fever free, they are not lethargic, taking oral feed, switch to oral antibiotics. So oral antibiotics advisable is amoxicillin clavulanic in a dose of 30 to 40 milligram per kg and cefixime 8 to 10 milligram per kg. So I think this is the only conditions where cefixime is being used to treat, because either the E. coli, the other bugs are almost 60 to 65% sensitive to both of these two drugs. So you can use either amoxicillin or cefixime in a case of fever without focus more than 48 hours only after sending samples. The other systemic signs, they can present with respiratory symptoms or ENT symptoms. So in ENT, otitis externa, acute suppurative otitis media are not uncommon. But again, the dose for this amoxicillin clavulanic is being used for acute suppurative otitis media, either amoxicillin. Amoxicillin is considered to be the drug of choice in case of ASOM, but you should consider giving this antibiotic at least for 10 days. Most of the respiratory symptoms would present with cough. So again, thorough examination is the key. Look for any signs of respiratory distress. If the patient is not in respiratory distress, they can be managed on OPD basis. What we found that most of the cough is because of the viral lesions. So the reason for the cough reflux, whenever there is a stimuli, they cause stimulations of larynx, trachea, and bronchi through the afferent lump of vagus nerve. The cough center in the medulla oblongata, there is an afferent nerve, and they would lead to laryngeal and respiratory muscle spasm, and they can lead to cough. What in neonates in less than 2 months, the most of the bacterial lesions, they affect the lung parenchyma. If the bugs are affecting the lung parenchyma, they cause less cough, whereas most of the viral infections, they cause they affect more airway, they cause more cough. So generally speaking, if the patient is coughing too much, the chances of upper respiratory tract infections are much more common. Even if it is lower respiratory tract infection, chances of viral infections are very, very high as compared to bacterial infections. So in NICU, I have seen many patients with large pneumonia, with ventilator associated pneumonia, with bacterial pneumonia. They generally never cough. Whatever we found with cough, either they come with either RSV virus, coronavirus, or adenovirus. So if you want to treat, please get a culture. If not getting culture, at least nasopharyngeal swab, they would, solve the problem, because you will get some report of virus, and then in that case, you can avoid too much of antibiotics. There are many drugs. They are used in a combinations in individual antitussive, antihistaminic, mucolyte, decongestant, pharyngeal demolitions. But out of all these, antihistamine is being commonly used in the OPD, even in infants less than 6 months, and specifically in infants less than 2 months of age. We found that these two drugs are very commonly being used in the OPD. One is cetirizine and one is hydroxyzine. The AAP, the FDA recommends that you should not use cetirizine before 6 months of age. However, they have found a very good safety data of last 30 years. They can be safely used in pregnancy, lactations beyond 6 months. And one of these studies have found that even a dose of 0.25 milligram per kg at 6 months of age, they are quite safe. They cause slightly somnolence, otherwise they are safe. However, hydroxyzine is nowadays very commonly being used for two reasons. One is for the URI, and the second, we found that in the cases of atopic dermatitis, because of the increased allergy infections, they are being very commonly used. This meta-analysis has found that infant where more than 5 prescriptions were used as a hydroxyzine, they cause lot of neuropsychiatric problem in future at 5 years of age or at 10 years of age, in form of tics, hyperkinetic, emotional imbalance, intellectual neuropsychiatric problem. So if you're using for a topic or something like that, first try not to use for shorter durations, and better avoid an infant less than 2 months of age, because there are lot of neuropsychiatric problems. What FDA has approved, that they have removed the use of phenylpropylamine, because there is an evidence that there is increased risk of hemorrhagic stroke. So try to avoid using PPA combinations at all. In 2008, the FDA recommended that all cough cold medications should not be used in less than 2 years. The company changed their guideline to up to 4 years. They have, tinker with the guidelines. In 2010, again, FDA and AAP changed the guideline to up to 6 years more. So nowadays, you have seen that most of the, drug bottles have specifically mentioned they are not safe for infant who are less than 6 years. So try not to use, specifically if you are encountering infant less than 2 months of age. So no cough syrups, no cough drops, no antihistaminics are safe or neither effective. What we can use, probably saline drops or spray. Avoid oxytometazoline. They are not recommended below 6 years of age. Oral histamine less than 6 months. Avoid. Sometimes we do use nebulization, specifically in lower respiratory tract infection with RSV or some adenovirus, just to clear these secretions. So both normal saline and 3% normal salines are being used. Both are safe. In case of bronchospasm, these three drugs are commonly being used in OPD practice, that is levosalbutamol, salbutamol, or budesonides. So let us see the evidence. Oxymetazoline, current FDA approved, is only beyond for 6 years, so avoid using oxymetazoline. Nebulizing medications, saline, both 3% salines are safe. Slightly, the Cochrane studies have found that if you use nebulized hypertonic saline, they may reduce just the duration of hospital stay of 9.6 hours. Otherwise, there was no difference. So you can use safely both saline and 3% saline. But if you're using too much nebulization, sometimes it can cause cough because of the spray. They can cause bronchospasm, and rarely they can lead to bradycardia also. Whether to use salbutamol or levosalbutamol in India, so levosalbutamol is being used here and there. So look at the evidence. If you look in last 3 decades in NICU, specifically in those VLBW or ELBW infant, they are at risk of chronic lung disease. They can lead to bronchospasm. So most of the studies have used salbutamol in a cases of BPD to improve the pulmonary outcome in case of hyperkalemia or TTNB. So what we have found that salbutamol is nearly safe if your heart rate is less than 180 beat per minute. Even 2020 meta-analysis of 13 studies found that even though there was no benefit, but there was no harm. What dose have been used? In a dose of 0.1 to 0.5 milligram per kg per dose as a nebulizer dose, or if you're using MDI inhaler, specifically in CLD infant, those who are sent on MDI spacers, they can be used 100 microgram per spray. However, if you're using levosalbutamol, so levosalbutamol is probably available in India. I could not find any study related to levosalbutamol. Even most of the product inserts suggest that we should avoid this levosalbutamol in an infant or any infant less than 4 to 6 years of age. So if you want to use any nebulizer, so you can use salbutamol. Why to use levosalbutamol? Because there is no study, no Western data is available, and we have enough data even for preterm infants. They are being used in a many conditions like BPD, hyperkalemia, or TTNV. If you want to use salbutamol, avoid levosalbutamol. Again, budesonide is not used for acute conditions. We have used in BPD as a prophylaxis, but if you're using budesonide, they can be used in a 0.25 milligram 12 hourly to 0.5 milligram once daily. They are not being recommended, so try to avoid in any acute conditions. The last is the role of oral antibiotic. So I was told that the where we can use oral antibiotics. So like in ENT conditions, probably ASM and otitis externa, you can use. Skin most superficial in stable neonate like in bullous impetigo or mild omphalitis, you can use. Respiratory, look for sickness. They require admission because the community acquired bacterial pneumonia are very rare. Community acquired LRTI because of the RSV and adeno are very common. They need comprehensive management more than the antibiotics, like your ventilatory management, the IV fluid, the nutrition. They are much more important than the antibiotic. In case of fever without focus, if you are strongly suspecting UTI, probably if your baby is stable, then you can offer oral antibiotic. Like only two, the amoxicillin, claviclinic combination is most commonly used antibiotic. Can be used in sepsis. The World Health Organization recommends that parenteral antibiotic in a health facility as the standard treatment for serious neonatal infections. So we should not use oral antibiotic for a cases of clinical sepsis, suspected sepsis. What is the use of role of oral antibiotic? Scope is that whether we can use a first line. No. So most of the studies have not used first line. Either they have switched from IV to oral, or they have used IM plus oral for possible bacterial infections, provided the patient is not sick, the infection is not deep-seated. If the patient required continuous monitoring, they should not be offered oral antibiotic. Community-acquired infections are mostly viral during the viral season, except UTI. There are many concerns with oral antibiotic. What are the concerns? If you use oral antibiotic, the target tissue concentration is reached very late in neonates. That is why we use IV antibiotic to achieve the target tissue concentration as early as possible. So even after IM injection, the time to reach the drug concentration are less compared to oral. You need very higher doses and frequent interval. One of the study have found that in OPD basis, when they use a moxiclav combination, they required in a dose of 80 milligram per kg to 100 milligram per kg per day to achieve the target tissue concentrations. Most studies used as a combinations IM plus oral or switch from IV to oral therapy or in cases of UTI only. What are the concerns? Concerns as that, apart from this UTI, preferably avoid giving oral antibiotic. What oral antibiotic being used in many studies? Cotrimoxazole and amoxicillin were used in a very old study. We have no idea. We have already discussed about the moxiclav. If they used in very high dose, 80 to 120 milligram per kg. Cephalexins being used in omphalitis and local skin infections, but nowadays MRSA is much more common, and you cannot wait for more than 48 hours. Call patients daily, look for the lesion. If they have systemic signs, try to switch to IV injections and then switch over to oral injection. Linezolid is being used where the VRE infections are there, where the osteomyelitis were there. And then if you don't want to use a long-term IV injections, they've been switched to linezolid. Ceftriaxones, I could find only 1 or 2 studies only in UTI, but I could not found any study where cefixime is being used apart from UTI. But if you look at the OPD prescriptions, the cefixime antibiotic is the most common antibiotic being used. So try not to use cefixime in any cases. So I think this is the last slide. When to use oral antibiotic? Yes, there are data are available when you discontinue IV antibiotic and then switch to complete the course of oral antibiotic. If the blood culture is positive, specifically GNB, it is very difficult to choose oral antibiotic. Is try to complete the course of 10 to 14 days of injectable antibiotic. Yes, in case of GPC gram-positive infections, to complete the long course like osteomyelitis, omphalitis, or liver abscess, you can switch from IV to oral like linezolides. UTI is the best suitable scenario. I think, sir, this was the last slides. Thank you.
Thank you. Thank you so much, Dr. Ankur. And it was very lucid presentation and lasted almost 1 hour. So I'm sure there are a lot of questions. But first to Dr. Ranjan for his comments, and then we'll request him to moderate the session as well. Over to Dr. Ranjan, sir.
Thank you, Dr. Kumar. Ankur, that was a very comprehensive and very informative talk. Given the context of office practitioners, they do follow up newborns, including NICU discharges at their outpatient clinic, and that target audience have definitely benefited by your talk. The content you have provided, the information you have given is very optimum, not more or not less, to be precise. I have been in neonatal practice. This is my 41st year in pure neonatology. I can tell you that I have only 12 to 15 medications which I use in my personal pharmacopoeia. I think that should how it should be. And my advice would be, if you don't remember the dosage, please refer. There is nothing to feel shy or embarrassed to check the doses. Small dosages books are there, and it is meant to be referred. And under-prescribing and over-prescribing may happen to some extent in office practice, but keep it to 5 to 10% only. And the scenario is that 4 out of 10 newborns are born in private sector, and up to 40% of our clinic patients are newborns and infants. So considering that, this program, which IIP Delhi has conceived and is executing, is very, very good. Once again, I can commend them. And Kumar, Ankur, you have been just awesome. So thank you very much.
Thank you, sir.
I am sure there'll be a lot of questions. I can see in the question and answer column itself, 22 questions. With this, I hand the mic. Once again, thanks for allowing me to be in this program. I learned a lot. It was a revision for me, and I thank you.
So be around, because I'm sure you will be contributing to answers also.
Yeah, I'll be around till the program is over.
Yeah, right. So Dr. Ankur, Dr. Parneet is asking vitamin K in NICU to babies on prolonged antibiotics. So do you use it?
No, generally we don't use, infant, specifically unless and until the patient is a case of neonatal cholestasis. Otherwise, we don't give, it's not been recommended.
Okay. And Dr. Dushyant wants to ask, vitamin D levels are for neonates only. These cutoffs of, you showed the cutoffs, whether they're only for newborns or for throughout population, deficient, insufficient, and
no,
sufficient.
this is for the neonates only. This is for the neonates only.
Right. So you did say, Dr. Ankur, that you should not mix any medication in breast milk. Does it mean that even MCT oil should not be mixed?
So first of all, I think most of us are not using MCT oil. Try not to use MCT oil. Try to look for what is the reason for not gaining weight. Just putting MCT oil won't work. Check for whether the baby is getting enough milk. They are losing calorie. They are not getting adequate calorie. Ensure milk. Still, if the baby is not gaining weight, then you ensure that there are alternative milks are available. Then you ensure. First, as a dictum, don't add anything to the breast milk. Don't mix anything to the breast milk. They can alter the taste of the breast milk. That can lead to the oral aversion. Baby would not like to, drink breast milk. So that's why there is always a risk of contamination. So there is, as a dictum, we don't mix any drugs to the breast milk.
Except human milk fortifier.
Yes, except for human milk fortifier.
MCT oil may be recommended for neonatal cholestasis in desperate situations, but not otherwise non-cholestatic newborns, right?
Yes, yes, sir.
Right. So we are all neonatologists have the same mindset that we don't want to use MCT oil. So please stay away. It only increases the fat or belly fat. It does not improve the brain, and it will artificially increase the weight, which is not good for the baby. Dr. Tarun Singh wants to ask that those iron drops, iron doses you suggested were prophylactic iron therapy, or it was therapeutic iron, which 2 to 4 milligram per kg you mentioned.
No. These all are the prophylactic iron therapy. Even for the
Right.
treatment purposes, the dose is now the lower on this side, not very high dose. Initially, we were using. So these all are the prophylactic doses. But
Right.
try not to use more than 3 milligram per kg in any scenario, and try not to cross 15 milligram per day at max.
So, Dr. A.K. Sharma, on behalf of IAP Delhi, I thank you for appreciating our program. And Dr. Naveen definitely said that you can use his contents. Those videos, YouTube videos, which you have on IAP Delhi platform, can be used for public uses or for your teaching of your residents. We have no objection in using your this videos. But if you want to copy paste the slides, then you have to take permission from the authors. So as far as the videos are concerned, I'm sure Dr. Ankur will also agree to this. Videos are on IAP Delhi platform and you can use it for teaching of the residents. Yes, that's all right, Dr. Ankur.
Yes, sir.
So Dr. Vino want to ask 24 sucrose gel is available in the country?
Yeah, it's available in the market. It's available
Right,
in the
right.
market.
So any drug for excessive rumination, Dr. G.K. Kapoor wants to ask. Excessive rumination.
So we have already discussed that he has asked that any drug for excessive rumination in breastfeed exclusive or only postural change. So first, there is no drug for the almost 30 to 40% baby can have some amount of GR, and most of the GR is not presented with GRD. They would be gaining weight, they are slightly fussy. So for that you don't need to add any samethicone. I have already told that the dicyclomine is not recommended. They are contraindicated during the first 6 months of life, and again probiotics have only mild role just to decrease the fussiness in the baby. And Nespegan has recommended there is no role of postural changes. Yes, for some behavioral issues they do improve if they keep the baby in the right lateral position or left lateral position. Otherwise, it's not going to help if the patient is really GERD.
So Dr. Ashwarya Adulia wants to ask, what is LE? I could not get that question. LE you mentioned somewhere in your presentation?
LE?
Yeah. I think there's maybe some, you can, Dr. Ashwarya, you can ask again because I could not understand what is LE. So though this is beyond the scope of this presentation, Dr. Rajesh Sharma wants to ask preparation of dopamine infusion.
So, if you're preparing dopamine infusion, you generally prepare in normal saline. Try avoid too much of the concentration because few of us do prepare dopamine in a 5 ml, 10 ml. Try to, dilute that to avoid the dopamine rashes.
Right. I think you already explained calcium multivitamin iron in 1.5 kgs and beyond. So Dr. Manoj wants to ask whether you will be using same in 1.3 to 1.8 and 1.8 to 2.5 kg separately, these multivitamins, calcium and iron.
For infant, those who are more than 1.8 kg or 1.8 to 2.5 kg, there is no need to add multivitamin and calcium. Only iron and vitamin 2 would suffice, and you have to continue till 2 years of the age. For infant who are less than 1.8 kg, yes, multivitamin would be required. So
right.
just to remember, 1 ml would be enough.
Right. Dr. G.K. Kapoor wants to ask how to collect in UTI. As you said, there is a need to do urine culture.
See, the gold standard test is by suprapubic or the catheterizations. So I think if you're labeling it as a UTI, so it's better to get suprapubic or the urinary catheterizations.
So Dr. Ankur, I may modify a little bit because if you are planning to start antibiotics, then you definitely do suprapubic and catheterized sample and you can decide after the reports come. But if you are not starting antibiotics, the suspicion is not very strong. Then you can use a Eurobag also, because in Eurobag, if the culture is negative, you can rule out sepsis. Where it is positive, then you definitely have to again resort to catheterized sample before you plan to start antibiotics? Because I understand that if an office-based pediatrician in OPD practice is suspecting UTI, it may be difficult for the pediatrician to catheterize sample in OPD or do suprapubic. So it may be still okay to do bag if you are not planning to start antibiotics.
So there
Is
is
that
one
okay,
study.
Dr. Ankur?
Yeah, so
Yeah.
there is
Right.
yes, sir. We do agree, sir. But still, there is a risk of contaminations. So there is one
Right.
study here. They have found that after feeding, what you can do, you can stimulate the baby's suprapubic area and try to catch hold the, I mean, the urine. Baby,
Midstream.
they would pass. Yeah, so they would pass the urine. So you can collect that.
Thank you. Dr. Sudhir wants to ask what type of oral sedation you use for echo or MRI? What drug?
I think still most of the cardiologists in OPD practice, they are using chloral hydrate, but they do understand that because many of them, they are follow-up case of preterm. The chances of complications would be high in case of prematurity. They can develop bradycardia, apnea, and even deaths are being reported. So nowadays it is not FDA approved, but if you're using, then use the dose appropriately, not more than, I mean, 50 to 75 milligram per kg per day, but
So
try
I
to
think
avoid.
right. The practical tip is that wait for the drug to act. I've seen that our fellows residents, they will give 50 mg per kg just when the alarm comes that send the patient. The
Yes.
drug will take time, and the baby does not get sleepy in half an hour or 15-20 minutes, and they repeat the dose. And after 4 hours, the baby is excessively sedated, sleepy, and then apneic episode. So give time for the drug to act. Give it at least 1 to 2 hours before the proposed medication, and have to be monitored during procedure also and before procedure also. Pulse oximetry should be done. As very rightly said, the chances of bradycardia, desaturations, apnea are high. So you should not leave the baby unattended in sedation, in MRI. And you must take consent of the parents whenever you are sedating any baby. That is NABH recommendation. If you are using sedation, you must take consent. And this aspect has been ignored in most of the practices, that you don't take consent for pedicloral. It is a must for any sedation for the patient. If you are doing, consent is mandatory. So Dr. Rajesh Sharma wants to ask, ES preparation of amoxiclav, do you recommend? That's a high dose, 600 mg of amoxiclav.
No, I think we are talking about neonates. So yes, contain 5 ml
Right,
of around 900 mg
right.
probably. So I don't know.
So Dr. Manjusha Nayak has asked a very, very relevant question, that you said that all cough, running nose medications are not good. They should not be used. What should we do if the baby comes with these symptoms, cough and running nose?
We have a safer medications available. Cetirizine is being used even beyond 6 months of age, though then you can use. However, cetirizine and hydroxyzine is being recommended for mainly atric area or allergic rhinitis. However, you can use the cetirizine. They are, I mean, recommended.
So
There is no
beyond
issue.
6 months, you can use cetirizine, and
Yeah.
beyond 2 months, you can use hydroxyzine.
I could not found the literature where they recommend that hydroxyzine can be used beyond 2 months of age. I mean, there is no
Okay.
recommendations. Yeah.
Okay. So you are still saying that don't use anything till 6 months, and beyond 6 months, you can use cetirizine, and less than 6 months, only use nasal drops and
Yes, sir.
maybe nebulizations.
Yes, sir.
Dr. Rakesh Kumar Bhatia wants to ask, any medication for babies not passing stool for a few days? Is it really needed?
So this is very common practice. Ask one question to the patient. If the patient passing stool daily, if the answer is no, then ask second question. If the patient is passing soft stool even when they pass a stool, that means your answer is very clear. That means this is normal pattern of the. If the patient is passing infrequent stool, I mean it is very hard, then you should consider for, I mean, ruling out something else.
Or can you use Livolac? That's what probably he wants to ask.
No, generally there is no recommendation. So there are a study from neonate, the glycerin supporter is being used even in the neonatal study, though they haven't found any change in the outcome. However, they are safe. So if you want to use, glycerin suppositories can be used.
Is ORS 75 commercially available? So I think the current WHO ORS
90,
is ORS 75.
Current is ORS 75, ORS 90, ORS 75 is available.
ORS 90 is only recommended for cholera, but
Yeah,
right
cholera,
now the
yes.
standard WHO ORS is ORS 75.
ORS 75, yes.
So cetirizine you already answered. For less than 6 months, you cannot recommend cetirizine. Salbutamol can be used in less than 6 months?
Yes, they can be. Yes, they can be used in less than 6 months. I mean, there is no issue at all.
In umbilical granuloma, Dr. Sukhdeep Kaur wants to ask, can you use mupirocin?
See, umbilical granuloma is, we are saying that this is not an infective granuloma. So if it is infective, there is other treatment. For isolated umbilical granuloma, common salt is equally effective, and then you can use. It's not, I mean, mupirocin is not recommended. Yeah, there have been steroids have been used, but you have safer medications. So why to use steroids or antibiotic? Antibiotic is not recommended for granuloma.
Maybe if there's a pus discharge and
Yeah.
it is, then you should think about other things.
Yeah, so then don't treat locally. If the granuloma is, I
Right.
mean, infective, don't treat locally.
And I think in granuloma, you should also try to smell. Sometime, maybe one in a year, you will also find a persistent uricus or BID, which is initially being managed as an umbilical granuloma. So make it a habit to just try to smell whether it is smelling like stool or urine, and then you can have a differential diagnosis. So, doctor, somebody wants to ask the nebulizations, Ipravent, colistin. Colistin nebulization. Are you using colistin nebulization?
So first, Ipravent, yes, there are studies available from the neonatal for using Ipravent, but they haven't found any efficacy compared to salbutamol. So salbutamol is again preferred. The second is colistin. So if colistin is being used in a condition where there is a pneumonia. So if you're talking about pneumonia in neonates, they are generally of ventilator-associated pneumonia. Yes, there are studies are available where you found isolated VAP without, I mean, hemodynamically stable. Probably they have few studies they have found an equally effective compared to IV or versus colistin nebulizations. Otherwise, colistin nebulization for isolated pneumonia are not being recommended, not as standard practice.
So we are not using it either. So colistin nebulization for VAP also we are not using. In any case, colistin is not a very good drug, and the sensitivity never comes sensitive to. They always say intermediate because the sensitivity parameters for colistin have not been set. Having said that, we do use colistin in babies when we are pushed against the wall and no other drug is sensitive, but still it is not a recommended medication. Each child has tremors after nebulization with salbutamol.
Yeah, tremor can happen, but they are generally harmless. So
They are
just you have to
harmless.
stop the drug. That's the only.
But Manoj Anand Gupta wants to ask that if you're using levosalbutamol and you feel, and the physician feels it is seeing the response, still do we have to switch to salbutamol?
Sir, so I have reviewed the literature. What I could found in the Western country, no one is using levosalbutamol. They found that this levosalbutamol is a product of salbutamol. They should work, but you don't know what is the dose of levosalbutamol. However, we are using salbutamol for more than 40-50 years, even an extreme preterm. They are quite safe. So why to change from, to a drug where the dose is not known and it is not recommended below 6 years of the age. So try to avoid this. Yes, you will find the response because it's a part of salbutamol only. So we are not talking about salbutamol. We are talking about whether it's a recommended or not recommended. If you have the choice of recommended drug, then why to change?
Right. So, Dr. Rakesh Kumar wants to ask, promethazine is prescribed especially in government hospitals. Is it safe?
Yeah, I do have fair idea, but I cannot comment on these questions.
Right. So, gentian violet for tonsillitis over topical mupirocin. I think Dr. Ankur also already answered that there is no pace of antibiotics routinely for tonsillitis. We have to take into account systemic signs also. So, can we give ORS to newborns? Dr. Pinky Gupta wants to ask.
Yes, we can give. Neonatal dehydration.
No problem.
Yes,
We
we
can
can
give
use.
ORS now. Dr. Manikant Kumar wants to ask, sir, we often avoid antihistaminics in infants for cold and running nose, but often parents are so anxious about running nose. They say that, doctor, my baby is not sleeping and crying even after saline, nasal drop or spray. In such condition, which antihistaminic will be preferable to prescribe when parents are very anxious and want antihistaminic?
First,
Difficult
rule out
question.
if the patient is a regular follow-up, try to counsel them. This is the only answer. You should know that what are the signs of sickness. If there is no signs of sickness, there is no point chasing cough and cold. You have to chase what is the breathing rate, what is the feeding pattern. What I have told you, the symptoms should not be disproportionate to the age. If the patient is breathing well, if the patient is feeding well, if the patient is gaining weight, if there is no breathing problem, respiratory rate is normal, then don't worry and don't chase cough, cold, runny nose. They would recover with time only. No drug can, improve the, cough.
So I think with experience, I can tell you, Dr. Manikant, if you tell the patient that I can prescribe medications, I know them, but they may harm your child. So if you use these words very clearly, that there are studies, there are reports that these drugs can really harm your child, and you underline that word, parents will always say, okay, then it's all right, also give me something safer. So I think it's a way of counseling which is going to help in these patients. S2 blockers not recommended in GRD.
No, no H2 blocker and no domperidone.
So now they are not recommended. There was a time when there was some recommendation, but now they are not recommended. Any role of fungal diastase?
Neither I've reviewed nor have any data because
Right. So I think Dr. Ashwarya wants to clarify LE is for UTI, LE. I think there may be some misconception or misunderstanding of LE. I could not understand. Sucrose
LE.
brand, Bharat wants to ask.
So I think again it
It
was
comes from
available.
Reptacos.
Yeah,
It
Vectacos.
comes from
Yes.
Reptacos. You can find it out because as a policy, we don't mention the brand names, but it is available from Reptacos. Antibiotics to be diluted in normal saline or D5.
So as per the product insert recommendation, but most of the antibiotic can be diluted in NS if you don't want to read too much.
Right. Except caspofungin,
Yeah,
amphotericin B,
like
you have to
amphotericin
take
B,
care.
yes.
Right. Any role of virazyme or fungal diastase? Again, I think we are not using fungal diastase. Dill oil and fennel oil effective. I think this preparation of simethicone also have dill oil and fennel oil, which is not doing any harm, but I don't think so whether they are really effective.
Yeah, at least you should avoid dicyclomine.
Please don't use soda bicarb for intratracheal suction. You will burn the trachea. Soda bicarb is a very severely alkaline solution. So for God's sake, don't use for intratracheal suction. You can really harm the patient. Normal saline is okay. Management of newborns who are not passing stool over 5 to 6 days. I think just Dr. Ankur already said, wait and watch, no medication required. Some babies are formula fed only, then what supplement should we add? So any this supplement vitamin D for formula fed babies also?
Sir, there is some controversy, but the global consensus for nutritional ricket prevention, they have found that whether the baby is on breastfeeding, partial breastfeeding, or formula feeding, for first 1 year, you should give vitamin D in a dose of 400 international unit per day.
IAP used to say that if you're using a formula and the dose is so much, then you may not.
Yes.
But all those are result tricky.
So I think
you can use 400 IU per day in all babies, not a problem. So can you use lactobacillus reuteri in colic?
So there is a meta-analysis available. They found that there was no, complications. Only the fussiness is fine. But what I have told you that most of the studies they have used L-Lutri, they found that they are effective only when the baby is on exclusively breastfeed. If the baby is on mixed feeding, on the partial breastfeeding, they are not going to help.
So exclusive breastfeeding Lutri is recommended. The bad news is it is not available in the market now. It get into some dispute as far as less than 2 years and IMS Act is concerned. So right now it is not available. But yes, Lutri has been grade 1 evidence for colic. Dr. Ramadou wants to ask, oral sedative safe for newborn? I think we said it's still chloral hydrate. It is best possible, but as such, nothing without consent. Do we use redo urine culture after completion of antibiotics? I think that's a good question.
So irrespective of type of infections, be it pneumonia, be it a UTI or be it clinical sepsis, there is no need to repeat to confirm. You have to look for the clinical response. That would suffice.
Right. So clinical response alone, if the patient does not respond and you have been using an intermediate drug or you're suspecting in vivo, in vitro resistance, then you can use, but not routinely. Dr. Ashwarya Dulia wants to, okay, I will remove, I will get into Ashwarya into the platform. Just a minute after I finish. Any drug for excessive salivation?
No, salivation generally, excessive salivation start by end of 3 months of life. They are part of routine development because babies start mouthing and putting hand in the mouth. They are part of a development part. They should be, it should be there. I think what is the harm in excessive
So triclophos sedation, we already said yes, 50 mg per kg is the dose. Asymptomatic child urine culture posting, should we repeat the sample? I think we should not.
Then why to do urine culture in an asymptomatic child?
Right.
Look for clinical symptoms.
Fexofenadine use and safety, Dr. Rajesh Sharma.
No, not in less than 6
months. Not in
months.
newborn at least.
Yes.
At least less than 2 years of age, fexofenadine has its own issues. But yes, beyond 2 years, 5 ml BD or 30 mg BD till 12 years, and you can use.
You have
Can
safer
oral?
drug cetirizine, then why to?
Yes,
You have
yes.
long-term data.
But if somebody wants to use because of less sedative effects, it's recommended beyond 2 years of age. Can oral Rentag be used in newborns?
No, no.
Yeah. Can you use syrup ibuprofen as analgesic, especially after vaccination if paracetamol is not useful?
I think, I mean, if you are
You can,
yes,
but
use.
see, if you look at American Academy, they recommend ibuprofen analgesic more often than anybody else. But you have to see that if you use repeated doses, they can get into gastritis. So paracetamol is still a safer choice. Lactulose syrup for constipation, we already mentioned. Siloderm cream can be used for diaper rash. Dr. Manju Rana wants to ask.
Yeah, we can use Siloderm use. They contain
Right.
zinc oxide or coconut oil. They are equally good.
Right. So topical eye drop in babies with eye discharge, we should start or we should wait for eye swab culture before you start any drug?
No. Generally, we don't send eye swab culture. So if you are
Right.
having infections, you give, tobramycin or ciprofloxacin, rofloxacin frequently between 4 to 6 hourly, depending on the severity of the lesion. If the lesion is severe, then you can use a frequent drop. Otherwise, 4 to 6 hours would be enough. There is no need to do a eye swab. However, in a conditions of an ICU outbreak, sometimes we do send swab culture. Otherwise, in routine cases, no.
So we are not recommending dual in nebulization.
No.
Best probiotic is out of scope of this presentation. Dr. Ashwarya, I'm going to unmute you very soon. MDI use in infants.
Yeah,
I
so
think we are.
I
Yeah,
think it's
please.
beyond this. I mean, but in ELBW infant chronic lung disease, they are on sometimes on Budocort MDI inhaler. We sometimes do discharge the patient on this. They are safe.
Right. So we are not recommending any calcium supplementation for jitteriness if serum calcium is normal.
No.
So metronidazole, clindamycin, NEC is absolutely no. We don't recommend because right now we do understand that the current generation antibiotics are effective against anaerobes also. So we are not using them in NEC. Using mucus extractors for running nose in newborns, I think that's a practice.
That's a practice, yes.
Right. Dr. Arvind wants to ask medication for proper digestion due to multiple stool in spite of counseling. Any due to digestive drugs? I think he's asking something like Yamu
I know,
or
Yamu. The
lactase
best
drops. We don't
digestive
recommend.
drop is breast milk, so try to ensure that.
Right. Okay, leukocyte esterase, Dr. Ashwarya.
Oh,
now your
so
question
okay,
is clear.
leukocyte.
Yeah.
Okay, I
Only
got
is
it.
leukocyte esterase, yes. Yes,
Yeah.
you should use leukocyte
So-
esterase, something like pus cells.
Yeah, so I think the current recommendation by pediatric nephrology and all, they have recommended that. So why they have recommended leukocyte esterase and nitrite are dipstick tests. So suppose your patient has come to your OPD, if you have a dipstick test like a protein in nephrotic syndrome, ask the patient to pass the urine, get a leukocyte esterase test and nitrite test. If they get positive, that means your screening test is positive. That means the negative predictive value is very high. That leukocyte esterase and nitrite is negative, the chances of UTI would be less.
So that is why. So we are saying that you use nitrate, do any sample with a lab which has nitrate label. So that is the point. Any more? I think. I start from back now. Protocol from umbilical granuloma with common salt. I think he already said that.
So put a pinch of salt.
Vomiting in newborn.
Yes, sir. Yeah. Yes, sir.
Any drug for vomiting?
No, if the patient is vomiting, again, you have to examine clinically that the vomiting is a part of reflux, and around 25 to 30% of term infant, they do reflux. If the patient is on formula feeding, they do reflux. If the patient is getting overfeeding, they do reflux. If the baby is gaining weight, there is no point chasing vomiting. And there is no point giving any antiemetic like metoclopramide or domperidone. That is not recommended. Yes, you have to rule out whether the vomiting is because of some surgical cause, some infections. At the same time, that means clinical thorough examination is the key.
So I think rescunate in NEC, people use bovine colostrum or something like that, NEC.
I
Have you
think
used the
Rescue
Rescue
Net
Net?
is probably is a probiotic combinations. I think where the NAC rate is more than 10% in the NICU they use, but in last 15 or 18 years I have never used any probiotics in my nursery. So yes, they have a grade 1 recommendation, grade A recommendations for using as a preventive strategy for probiotics in NEC, specifically in ELBW infant, but I haven't used. I think most of us are not using probiotics for preventing NEC.
Right. At Gangaram also, we are not using any routine probiotics for NEC prevention. So, is any role of early morning urine sample for UTI in OPD patients?
The only thing is that getting urine sample is the tedious task. So try to get urine sample. That is the only thing. Any sample would be helpful.
Right. Digestive enzymes in colic, I think we are not recommending. So I think we have finished with the questions. Dr. Ashwarya, your question has also been taken up. We are already 1 hour 34 minutes into this. So over to you. I think thank you so much. Dr. Alok is still there. So Dr. Alok, you want to say something?
Yes, I think Dr. Ranjan also wants to comment, and I have been asked this question many times, that what is the standard protocol, and this question is to all three of you, Dr. Ankur, Dr. Pankaj Garg and Dr. Ranjan sir. Ranjan sir, आप video भी on कर लें, and after this, what is the standard prescription on discharge slip from your hospitals for a normal healthy newborn, which is the 99% case? पंकज आप बताओगे पहले या सर? तो लंबा
go ahead Pankaj.
पंकज and Kumar, आप.
Dr. Alok, say it again. What is the question?
The question is, what is the normal average, मतलब normal discharge slip prescription of a healthy newborn, uneventful? Just
only vitamin D. Only vitamin D, 400 IU per day. That's the only thing recommended apart from breastfeeding.
Yes, I follow suit.
Yes, sir.
And Kumar?
Yes, sir.
So I think the viewers, this message is clear. First advice should be breastfeeding. Number 1. Number 2 is this vitamin D, 400 international unit. Number 3 is danger signs explained and report SOS. Watch for skin care and jaundice. थोड़ा ऐसा, Kumar, please elaborate कर दो जरा सा, so that this message is going all over the country.
So I think, sir, you're absolutely right. So I mean, the most common reason for readmission for infant, most common for shall I continue, sir?
Yes, please continue.
So most common reason for readmission is that because of the not getting enough milk, because of the poor latching. So ensuring breastfeeding is most important. And before discharge, you look for some risk factor. So we have been talking about infant, those who are more than 1.5 kg. There is a group of infant late preterm. I think Ranjan sir is there. So late preterm, they look like a term infant. They are large, but the readmission rates are very high. So counseling according to the risk factor is very important. If your infant is 1.8, between 2.8 kg, if they are slightly preterm, that is 34 to 36 kg, the need for readmission would be high. So ensuring feed, expressing of breast milk, and sometimes early follow-up would be required if they are falling under risk factor. As far as supplementation is required, only one supplementation if your baby is more than 1.8 kg, that is.
And another query is a line or comment about the screening, neonatal screening, OAE, BERA, or metabolic screening. What to be done, when to be done? Is there a universal guideline being followed at your places? Screening for thyroid, like Dr. Ranjan sir?
Yeah, see the screening tests, one of the problems even today is sending the screening test and not following up the results. So in the discharge summary, if such a case is there, it should be very clearly mentioned, and it is very important medico-legally also to document that. But like, for example, late pretermers, it should be urged that they come for follow-up within the prescribed time. Otherwise, they'll come for readmission. So that has to be avoided. And screening tests, different institutions have their own protocols, every screening, complete screening, but not screening for thyroid is, I think, is equivalent to a criminal offense.
Sir,
Sorry, sir, I
good,
lost
good
connection,
afternoon,
sir.
sir.
I think.
Sir,
Yeah, say
Sir,
Aishwarya.
myself, Dr. Ashwar Adoli, consultant from Ursula Hospital, Kanpur. Sir, first of all, thank you for this enlightening session. I'll not take more than 5 minutes of yours because I have a lot of queries, sir. One of my queries has been answered that leukocyte esterase has to be done in case of UTIs. But other questions also I have. My first question is, what should we give for UTI in a patient less than 6 months of age since citizen is not recommended?
No medications, Aishwarya. Can you hear me? Am I audible?
Yes, sir, you are perfectly audible, sir.
So the first thing is that whenever you're treating an infant or child, first you want safety. Safety is much more important. So cough cold,
Definitely, sir.
yeah. So cough cold, in most of the time, cough cold is not going to, harm the baby, and you don't want to chase the cough cold. You chase the normal clinical symptoms. The baby is having respiratory distress, they would require hospitalization. If the drug is not
Definitely,
safe,
sir.
if the drugs are not safe, then why to use? Use
So,
nasoclear. If required, you can.
yes, sir. Yes, sir. Please go ahead, sir. Please go ahead, sir. I'm all ears, sir.
Okay. So avoid any medications which is not being recommended. So
So
none of the
histamine,
Question
no
answer some
antihistamine.
ಎಷ್ಟು ಉದ್ದ ಆಗ್ತಾ ಉಂಟು
no antihistaminics.
concluding remarks.
Yes, sir. Sir, my another question is, sir, 2-3 questions are remaining. Sir,
Okay, go
second question
fast.
is, any role of Vitazyme or fungal diestrase, sir?
So no role at all, dear. Vitazyme, dicyclomine, methicone, dill oil, no role at all. It is your counseling which is required. Look for the symptoms. Why baby is fussy? Why baby is crying? Why
Yes, sir.
baby is continuously crying? Always try to look for other symptoms. Rule out maybe sometimes hernia, sometimes because of the ear pain, sometimes otitis externa, sometimes UTI. There could be many factors. It is not the dill oil or the samethicone would help. Yeah. So try to
Sir,
avoid, I think at least avoid dicyclomine during the
yes, sir.
first 6 months of
Sir,
life. Yes.
I usually refrain from quoting medications, but still, I know Gastrica, which I prescribe sometimes, it contains gel oil and fennel oil. So, are they effective anyway?
See, don't go by the recommendation by the medical representatives. Try to review the literature.
No,
It is
sir.
not
It is
recommended. Neither
written.
it's
It is written in the product insert that the constituents contain gel oil and fennel oil. I just want to know
yeah.
if they are effective
No,
in controlling
not
colic or.
no, dear, not effective.
Yes, sir.
See,
Sir,
colic, if you
yes,
look
sir.
at the natural course of colic, they generally start with second week of life. Peak could be around 4 weeks of life and they can last 4 months. If you know the natural course, then you can counsel the parents. This is the natural course.
Yes, sir. Sir, my next question is, if the patient is not improving on salbutamol, can we switch to Duolin because it contains
No,
anti-cholinergic?
we have already answered that. Yes, if you want, if you feel that clinically there is a bronchospasm, you can use bronchodilator, and safest bronchodilator is salbutamol. There
No,
is no
sir.
point adding. No, yeah, I'm getting your
Yeah.
point. So there
Yes,
is
sir.
no point adding ipravent or duolin combinations.
Sir, up to what age? Sir, up to what age we can't add Duolin?
So
Ipravent?
no, we
So,
are talking about neonates. I mean,
Okay,
less
sir.
than 6 months.
Understood, sir.
so
Sir,
the Shakya impairment leads to drying of secretions, and
Yes.
newborns cannot really release that.
definitely, sir.
So it's better to avoid it in first 6 months of age.
Sir, my last question for today. Sir, what would you, as a senior pediatrician and neonatologist, recommend as the best probiotic for neonates? Because earlier, where I was working in a government setup, they usually used to give Enterogermina, Bacillus clausii.
So the best probiotic is breast milk. Breast milk contain all the probiotics. Probiotics won't give you any relief to the symptoms for which
Definitely, sir.
you are
I
actually
agree.
treating the patients. Be it acute gastroenteritis, I mean beyond neonatal period I'm talking about. So
Yes, sir.
probably zinc and ORS is much more helpful. They have been well studied. They have found to be effective.
But,
So why to? There
sir,
is no word best.
But
They can decrease the
actually,
1 day duration of diarrhea. They can decrease 1 day duration of diarrhea if you use an antibiotic associated diarrhea. to prevent antibiotic
Yes, sir,
associated
that I
diarrhea.
understand, but the attendants keep on pestering me. That's
That's why they are coming to the doctor. Na? You have all the rights to counsel the parents. Okay.
Yes, sir. Sir, my simple question is that if I have to prescribe one, which one should I prescribe for
You
that
should not
candidate?
prescribe anything routinely, Dr. Aishwarya. You are crossing the time limit. So we are saying that we are not recommending it routinely. And NF has recommended multi-component, multi-strain probiotic for prevention of NEC. But there is no multi-strain probiotic available in Indian market as of now. So we are not using
Okay, sir.
any probiotic routinely.
Understood, sir. Thank
Okay.
you. Thank you so much, sir.
Okay. Thank you.
Thank you, Dr. Ankur. Thank you, Dr. Dr. Ranjan Pajawar, sir, for your words of encouragement, and Dr. Alok Bhandari, sir, for giving us this platform of IIP Delhi to do these useful activities. As you can see, the talk lasts 1 hour and the discussion lasts another 45 minutes. This is the strength of this program, and we make it a point that we answer all the questions, however insignificant or irrelevant they may be, but still we try to answer so that the queries are sorted out. And with these, thank you so much. Bye, sir. And this
Thank
will
you,
be
sir.
recorded,
Thank you all.
person will be available, which on the platform itself, which can be used after 24 hours. Thank you so much.
Thank you, sir.
Thank you.